Hello, everybody. I hope you're having a good day. Welcome to the next presentation in the Decoding COVID series. This series has been put together to allow people to learn as much as they can about the SARS-CoV-2 virus and COVID-19, which has basically changed all of our lives in a pretty amazing way. The first two sessions have been very, very well received, and we're very happy that people are finding this to be a very useful seminar series. I am thrilled today to be able to thank Cap Powell, who will be introduced in more detail by Dr. Rounds in a second, who is joining us today from New York City. What he's been through in the last 2 weeks is something pretty amazing, and I'm sure he'll tell us about it, and he will share the insights that he has had from being at the bedside of these very sick patients. So without further ado, let me thank Dr. Powell for taking the time to talk to us today, and let me turn it over to Dr. Rounds, who will deal with the administrative stuff up front and then introduce our speaker today. Thank you.
Good afternoon. We're really pleased today to have Charles Powell visiting us from New York in cyberspace. And he'll be talking about COVID-19 and acute respiratory failure. Cap is director of the Mount Sinai National Jewish Health Respiratory Division. He's professor of medicine, pulmonary, critical care, and sleep medicine at Mount Sinai School of Medicine. He received his MD from the University of Chicago, did residency at Columbia Presbyterian Hospital, pulmonary critical care fellowship at Boston University, and he's been at Mount Sinai doing research on the role of the tumor microenvironment on the growth of lung adenocarcinoma. And this was working out really well, and a few weeks ago something else happened. And he has been on the front lines of caring for really sick patients with respiratory failure due to this virus. So we're really happy to have him here today. A few housekeeping matters. Please enter your questions in the chat function of the Zoom presentation. Dr. Powell has disclosed that he's received research grant support in the last 12 months, but there's no financial relationships with this particular presentation. So without further ado, Cap, take it away.
Thanks very much, Sharon. Dr. Elias, it's a pleasure to be here. As Dr. Rounds was saying, I was previously scheduled to be up at Brown this week talking about something totally different. But the circumstances have changed everybody's lives, so the topic has changed too. What I thought I would do today is take you on a journey, the journey that we've been on for the last several weeks. And I'll take you through this journey really through the many hats that I've been wearing during this COVID pandemic. And those hats include my role, of course, as the system chief for the Pulmonary Critical Care Division. And of course, we, like you, are on the front line for responding to the pandemic. I'm also the medical director for the System for Respiratory Care Services. So we were entrusted with ensuring that we had sufficient supplies for ventilating patients who required it. I also have a system role for providing staffing to critical care units throughout the health system, and I'll take you through that. And of course, the hat that we all wear is we're physicians, and we're caring for quite sick patients with an illness we haven't seen before, and I'll introduce you to that perspective also. You've all had a lot of opportunities in your previous talks to learn about COVID and opportunities to read about COVID. More opportunities than I'm sure I've had to read about COVID. And so we'll learn together, and I'll give you my perspective of where we were, where we are, where we're going to be, and I'm happy to have a conversation from your perspective also. So what I want to cover today really is the journey that we had in preparing for the pandemic surge, which really at the onset was a volume problem more than a disease problem, meaning that the crucial challenge was to ensure that we would be able to provide care to all the patients who presented to our hospitals who needed care because they were ill with COVID. And that was a daunting challenge that we were facing, and one that we never faced before, and one that I think we all hope we never face again. And I will go into a little bit of detail as to what we did in terms of making sure that we were able to deal with any potential supply constraints in terms of personnel, in terms of equipment, in terms of beds. And I'll tell you our approaches that we used to address these issues and how we were guided to try and understand what the demand might be. And then once we get past the peak, I'll share with you some of our observations that we made at the bedside about what the course of COVID pathophysiology is as it pertains to lung injury, ARDS, if you will, what we've learned from that, what we're doing about that. And then at the end, what I also would like to spend a few minutes on is how we're going to approach the post-COVID world. I think about a week and a half ago, 2 weeks ago, everybody was saying, can't wait to return to normal. I think now we've been sufficiently disabused. We are not going to return to normal. We are going to return to a different normal, a better normal, a new normal, if you will, and we can discuss some of the issues that will go into determining what that new normal will look like for us in healthcare and in life in general. So I want to level set a little bit. I know everybody's seen COVID across the country and around the world. I want to give you what the New York City experience has been, particularly as it pertains to the magnitude of the disease that we've seen here in New York. And there'll be many questions. Why is New York the epicenter? And don't know. The couple potential reasons has to do with us being an international travel center. We know epidemiologically that the virus that came to New York likely came from Europe. And we also know that New York as a state, and even worse as a city, was late to introduce social distancing and mitigation practices. And I think it was all those reasons combined that led us to be the epicenter for COVID. So this is data from just the 16th. It's just 4 days old. We had 126,000 cases, 33,000 hospitalized patients in New York City, with 8,400 deaths. And then there are another 4,200 people who died. They didn't have a specific diagnosis of COVID, but very likely they had COVID as well. And then they expired. So potentially up to 12,000 deaths in New York alone. It really speaks to two aspects of this virus. One is it's incredibly contagious, and two is it's quite fatal. And I think the estimates of the case fatality rate seem to hover around 2% right now. That's the bit of the US experience, and we'll have to wait and see whether that is the true number. It's hard to really know that number since the denominator has never been clear because of the absence of testing that we as a country have had since the inception of this virus. So now I'll also set the ground a little bit to tell you about the Mount Sinai Health System. So we're the largest health system in New York and one of the largest in the country. We have 8 hospitals in the boroughs of Manhattan and in Long Island. At rest, meaning pre-COVID, we have about 2,500 beds. We see a lot of patients, 4.1 million patients a year, and we have practices all over the tri-state area, 410 to be exact, with a couple in Florida and elsewhere, and 42,000 employees. This is a slide that was prepared by our president of Mount Sinai Hospital, David Rich, that he showed at a CDC webinar that was held just last Friday. And I'll walk you through the timeline, and I'll stop at a couple junctures and then I'll come back to the timeline. So we'll start at the very beginning, which is a very good place to start. It starts in December in China. And I'm sure now we can all recall reading about in the New York Times these mysterious cases of respiratory illness that seem to emanate from people who went to this fish market in Wuhan. And they had a respiratory disease that wasn't quite well characterized. And there was a thought that it could represent a very infectious, transmissible organism that could end up being a pandemic. I, like most of you, probably thought, this is an issue, they'll take care of it in China, and even if they can't take care of it in China, it'll stay in China because we in the US have a real strong infrastructure in terms of epidemiological surveillance, in terms of preparing for possible pandemics. We've done it before with success as it pertained to other pandemics that we've been exposed to at a smaller scale. And so I think most of us had the false notion that we would be protected from this pandemic reaching our shores. And we probably would have if we had a appropriate, robust response to the virus starting in December or in January. But it started in December and it emanated from there. And of course, it went to Europe. And nobody took anything for granted that we were not going to be affected by it. So the Mount Sinai Health System started planning for this in early January. So our Emergency Operations Center opened, and I'm sure it was similarly the case at other sites around the country, making preparations to have the teams in place to be able to make preparations for the pandemic. Should it hit our shores? Should it hit our particular cities? Should it hit our particular hospital? So we started that on January the 7th. We started working on tools to screen patients. We were hampered, like everybody else, by the lack of reliable, widely available testing. But nevertheless, we made preparations to try and be able to meet the demand for testing. And we failed like everybody else in our country. We did drills for COVID-19 to be able to be prepared for when it came. We had a town hall to talk about what the situation was in China. And then shortly after that, the first cases became identified in the state of Washington. So right around this time, we leveraged a relationship that we've had for a long time with pulmonary physicians in China. I in particular have affiliations with 5 hospitals in China. I travel there twice per year. We have clinical and research collaborations with some of the top institutions in China. Namely, one that's most relevant here is the West China Hospital in Chengdu, which is the 2nd ranked hospital in China. And as I'm sure you're also aware, when the outbreak occurred in Wuhan, scores and scores of doctors were sent from all over China to respond to this pandemic, 40,000. And this is in the setting of there being multiple healthcare workers infected by COVID in Wuhan before the new doctors arrived. So at least 3 of the doctors who I knew from West China Hospital were stationed in Wuhan, and we were in communication during the entire time that they were there. We used WeChat for that. And then as the outbreak became more prevalent in the state of Washington, and as it became clearer that we were going to see this in New York, we hosted a teleconference with the doctors in China. And the doctors on the right are the members of our steering committee for the division. And so we had the opportunity to pick the brains, if you will, from the doctors in Wuhan about what their experience was. We wanted to learn how they were able to be protected from becoming infected, because after that initial wave of healthcare workers were infected in Wuhan and new measures were put in place to prevent infections, there were no more infections of healthcare workers once new measures for using PPE properly and establishing COVID positive units was established. So we wanted to learn that experience. We wanted to learn what their observations were with regards to the pathophysiology of disease, with regards to the response to treatments. We talked about steroids, we talked about tocilizumab, we talked about other investigational treatments that they had some experience or didn't have some experience with. We talked about the length of stay on a ventilator, which in their eyes was about 2 weeks. We talked about their mortality, which was 50% in the ICU. And so that kind of gave us some expectations about what we might expect in New York should we confront the surge, acknowledging that there are many aspects of our healthcare system that are different than in China, and acknowledging that the genetics and the epidemiology of the disease may be different in China compared to New York. But it did provide us with more information than we had before, and we were grateful for that and remained in contact with them and still do. And then actually as their epidemic and pandemic waned down, then they were able actually to send us supplies. And we received supplies from multiple sites in China, not just Chengdu, but also Shanghai and Beijing. They sent us N95 masks, they sent us gowns, they sent us gloves, whatever they could do. They put us in contact with ventilator companies. So it was a real nice demonstration about the power of relationships and also the spirit of helping out colleagues, which we see every day domestically as well. So now I'm showing you the course of the pandemic in New York City, and these are data from the New York City Department of Health. The teleconference that I just mentioned to you happened on March 1st. So that's when they're very, very small little boxes on the left of the graph. And it gave us a little bit of lead time to be able to be prepared here. And you can see, and these are the number of new hospitalizations per day in New York City. And you can see it really starts to climb up around March 22nd and March 29th. Scores of patients presenting to multiple different hospitals around the entire city of New York, overwhelming multiple emergency rooms, overwhelming multiple hospitals. It was really a dramatic surge that affected different hospitals differently, in part depending upon what the nature of patients they cared for before COVID. Some were really truly community hospitals that just took care of maybe 20 ventilated patients at a time, to tertiary quaternary hospitals that were used to taking care of large numbers of critically ill patients, some of whom were better prepared than others for the pandemic. And I also want to share with you information that we were able to learn together about the types of patients that we were seeing with COVID. And on the left-hand side, I'm showing you the breakdown in terms of the patients who have COVID. These are the cases, they're on the left. And you can see that the distribution in terms of age is about pretty similar, whether somebody's 45 or somebody's 75. It's not much different in terms of the age distribution, I think, in terms of COVID. But when you look at those who are hospitalized on the right, you see it's quite different. And there's an enrichment in terms of who's hospitalized for people who are older. It's higher than in age 65 compared to 45, and even higher in age 75 compared to 65. Now, is that due to the difference in the impact of the virus on individuals who are older compared to those who are younger? Or is it due to the comorbidities they bring to the table when they show up? Or is it both? Probably the latter. And we also see differences when we look at gender. There's a difference in terms of incidence of COVID by case in women versus men, but that difference is magnified even more if we look at hospitalizations. So it seems to be that gender is associated with a worse course of disease. And when we look at our data with a bit more granularity, and we look at the risk factors that are associated with progression of disease, meaning need for utilization of critical care services or need for intubation, as an example, we see a few risk factors pop up. Age, gender, male versus female, obesity, and diabetes. And hypertension kind of sits there on the cusp as to whether or not it's an independent risk factor when we remove diabetes. But those are the risk factors that are associated with progression of disease, severity of disease, and we see that also manifest by the data I'm showing you in terms of the distribution of cases and the distribution of hospitalizations. So a lot of lessons to learn, I believe, in terms of what makes somebody more or less likely to be sicker than another individual. There was a question that came up on the chat, whether severity of illness may be due to differences in exposure to the virus in terms of quantity. I'm not aware of any data to say there is. I do think that there are host factors that are predominantly important here in determining who is going to have a more severe course than another person. And some clues that the metabolic syndrome phenotype may be associated with progression of disease probability compared to somebody who doesn't have that metabolic disease phenotype. I told you that I would speak to how we were able to try and gauge demand for services and demand for resources. And to do that, we use accepted methods for developing models for projecting the disease course that we might expect in terms of the volume of hospitalized patients in the health system. And we adopted the model that was published by the University of Pennsylvania. It's a very good model. It takes into account a variety of different factors, including the incidence of infections in a particular area, the population of an area, the marketplace of the health system, ours is 13%, the impact of social distancing, which at the onset was 0 because we weren't social distancing at the onset of this pandemic. It takes into account the anticipated length of stay and mortality as well. So on the left is the model that was generated on March 24th. And this is a problem. For those of you who were listening to the numbers that I gave up front, I described the Mount Sinai health system. And I said that we had 2,500 beds in our health system. We, like all hospitals in the state of New York, were requested, or more likely required, by the Department of Health to increase our capacity to be able to meet the surge. So our target capacity that we strove for and we hit was 4,200 beds. But if you look at the projected peak at March 24th, it's 26,000. And that's just for the Mount Sinai health system. There is no way our health system, nor any health system in the New York area, could accommodate the number of patients who could potentially come to our system as a result of the COVID pandemic. But nevertheless, we had no option but other than to prepare for this surge by making sure that we had a sufficient number of beds, a sufficient number of ventilators, and as many as we could come up with. And I'll tell you about some of the strategies that we did. Now, at the same time, starting around March 18 or 19, New York started to apply social distancing, stay at home, closing the schools. And what we saw was every day, the projected peak decreased. It decreased from 1,000 to 2,000 and pretty consistently every day. And the only thing that changed was the onset of social distancing and the mitigation steps. So on the right-hand side of this slide, I'm showing you the data from just 1 week later, where the peak had gone from over 25,000 to now about 11,000. So this is around March 31st. And now we're really in the thick of this right now. We right now, the blue dot is where we were right now. We had about exactly 1,000 patients in our healthcare system. So we're moving quickly up from 0, where we were about a week and a half ago, to 1,000 in our healthcare system, with a projected peak still beyond our capacity. So what did we do? So now I took you through the New York City response. So the school is closed on the 16th. In retrospect, too late. So we start introducing testing, and we start now making sure that we have capacity. And I'll take you through how we develop capacity. First, it was quite clear from the experience in China, in Italy, in France, and in Washington that a large number of patients who are admitted to the hospital, anywhere between 25 and 40% of those admitted to the hospital, would require critical care services. So we needed to increase our capacity for critical care services across the whole health system. And I'll just show you an example of what was done at Mount Sinai Hospital in particular. We have 94 licensed critical care beds, but we were able to increase our capacity to have 240 beds capable of delivering critical care services in our hospital. How did we do it? We did it by creating new ICU'S with negative pressure. How did we do that? Well, on the right-hand side is a picture of our hospital from the outside. And everywhere where you see one of these boarded up windows with a hole in it, used to be a window, but now there's a hole, and the hole attaches to a HEPA filter. So we were able to convert any room in a new ICU that had a window to a negative pressure room by punching a hole in the window and connecting up to a HEPA filter. We took all of our PACUs and we converted them into ICUs. And we took some of our floor units and converted them into ICUs. And that still wasn't enough. So then we put 2 beds in many of our ICU rooms. So we were double occupancy in many of our ICU units. And that was able to get us up to the level where we would have these 240 ICU beds. We also created space for beds in places that they didn't exist before. So on the left-hand side, that's Central Park. Normally, you would just see the ball field and the outfield would just be grass. But now what you see are these white tents. And these tents are medical facilities that are being staffed by a charitable organization called Samaritan's Purse. They can house about 60 inpatients, and there's another tent that can house 10 critically ill patients. It has ventilators and oxygen supply. So that increased our capacity a bit. We also created bed space in the lobby. So on the top on the right is the way our lobby looked at the initial steps of creating new units. So it's a beautiful open air lobby with glass ceiling that you can see on the top, and a nice wide open space. It's kind of like the Sinai watering hole. And you can see the scaffolding has gone up on the right, and within a week, it was ready for business. And each room was able to hold at least 1 patient with oxygen, with Ethernet, with water. And that went up in a matter of about a week and a half. And thankfully, we haven't had to use all of it, but we had to use some of it. One of the real concerns that we and other institutions had around Manhattan and around the state and around the country was whether we would have enough ventilators in our health system for all those who needed critical care support with a ventilator. And I mentioned to you up front that one of my roles is I am in charge, the medical director of respiratory care services. And at our baseline as a health system, we have approximately 700 ventilators. It's enough, it's more than enough. But starting in January, we started sourcing ventilators so we could increase our stock supply. And we sourced another 800 ventilators domestically and overseas. And we're able to increase our stockpile, both in terms of ventilators we had on hand and ventilators that have been and still remain on order. Our target ventilator number was 2,000, and we were just about able to get there in terms of having ventilator capacity for 2,000 patients if we should need it. But given the modeling that I showed you, it wasn't clear that 2,000 ventilators would be enough. We had capacity for 4,200 beds in our health system, and therefore, in total worst case scenario, maximal scenario, we could end up having 3,000 ventilated patients. So what would we do? Well, around the time we were preparing, we received a donation of home BiPAP ventilators from the Tesla Corporation. And my first reaction was, okay, but we're not really enthusiastic about using BiPAP through a mask in a patient who may have COVID, given concerns about aerosolization of the virus and risk to healthcare workers. And so then the next question was, okay, so we're not really enthusiastic about using it in that setting as a non-invasive positive pressure ventilator and through a mask. Why can't we think about a scenario where we connect these powerful home devices to an endotracheal tube and use it as a alternate to a conventional ventilator if we don't have a conventional ventilator available? And so at Sinai, we're fortunate. We've built up our sleep enterprise here over the last few years, both on the clinical end and on the research end, with world-class sleep researchers representing the spectrum of epidemiology, mechanisms of disease, and physiology of sleep and physiology applications of devices for sleep, led by David Rappaport. And so my question to the team was, can we take these home devices and convert them into a ventilator that could be used in the ICU setting? And David and the team said, yeah, we can do that. And I said, how? And they said, we'll show you tomorrow. So they developed a protocol that's essentially overnight. We're able to create a circuit that would connect the BiPAP device to an endotracheal tube using widely available respiratory therapy materials with incorporation of HEPA filters to capture the exhaled gas. And we quickly were able to test that in the simulation lab that's run by our anesthesia group, figure out the best way and the best order for how we could incorporate spirometers to measure the volume of gas delivered, the pressures of gas delivered, the FiO2 of gases delivered, be able to hook that up to monitors that we could place outside of the room, and even better, to hook it up via remote control so we can monitor and control these home devices from outside the room. So the team in very short order was able to take us from the concept to a protocol that we're able to simulate in the lab and also apply to patients in the clinical setting to determine that it did indeed work. We then received additional donations of these devices and additional donations of other similar devices. The protocols have been modified, and our goal all along was to make the protocols widely available, and they are widely available and freely available to all who may need to incorporate this strategy. The protocols also are accompanied by training videos that are also freely available on our COVID-19 website. The circuit looks like this on the left. The device is this little, you can hold this in the palm of your hand. It's truly small. It packs a lot of power. And then we connect it to a filter here, bleed in some oxygen, and then the expiratory tubing again hooks up to a filter. This is a spirometer, and then it goes through a humidification device to the endotracheal tube. It works well. It has limitations in that it can't reach the inspiratory pressures that would be required to ventilate somebody with a very stiff lung. It doesn't reach the FiO2 requirements of somebody who may require 70, 80, 90% FiO2. And so the setting that we conceived of potentially using this type of approach in would be a patient who would be initially ventilated with a conventional ventilator during the acute setting, and at the point where we determined that the patient was able to tolerate settings that would fit into the parameters that the machines could reliably deliver, then we would swap out that conventional ventilator for this device in times of shortage. And then we would have that conventional ventilator available for the next acutely ill patient as they came along. In parallel, as a side note, the anesthesiology team did a really nice job in developing a modification for a split ventilator protocol, which is the next level of risk beyond this. The main risk of the split ventilator protocol, when you take one ventilator and you hook it up in essence to a T-piece so that there are two inspiratory limbs that go to the patient. The main problem for that is that if there's a change in compliance of one patient, it will alter what is delivered to the second patient. And the modification made by the team at Sinai was they were able to create via 3D printing a valve structure so that the resistance could be altered such that the delivery could be done in a fashion that was the same for the two patients. That was considered a potential last-ditch strategy that would only be used in the setting. There were no conventional ventilators, no home BiPAP devices, and then the split ventilator protocol would then be called into play if necessary. Fortunately, we didn't need to do that either. And this is just to show you that over the course of time in the health system, the capacity that we built up in terms of conventional ventilators was more than sufficient to meet the demand. And so we were happy about that. We were happy that we didn't need to use those BiPAP devices. And we've now made them available to other entities in New York State and beyond who do have a need for ventilators or think they will have a need for ventilators. And we've made the devices and the protocols available to those settings. So I talked about beds. I talked about rooms. I talked about equipment. I didn't talk about people. So we were really in dire straits because we didn't have enough doctors to care for all the patients who were in our health system. And this was about the end of March. And much less did we have enough doctors to be able to meet the surge that was projected by the model should that hit. But first things first, we needed to make sure we had enough doctors at the time of March 31. And we had heterogeneity across our health system with regards to this. We have some small hospitals and some big hospitals in our health system. We had more than enough doctors in Mount Sinai Hospital to take care of the surge, but we didn't have enough doctors in our community hospitals, which were really under a lot of stress. Our community hospitals typically have 200 beds and 20 critically ill patients, but now they had 240 or 250 patients. The emergency room was full of patients with acute respiratory failure, and there were at least 50 intubated patients in the hospital. They never had that before. And the crew of 4 intensivists couldn't handle that. So we went on a concerted effort to recruit staff from a variety of different sources. I won't go into the details on what our sources were, what we did, but we brought in about 350 providers from around the country to help us with the response, both in the critical care setting and in the hospitalist setting. That was step one. Step two was to put those people in position where they could effectively and efficiently deliver care. And many of the doctors we brought in were not experienced intensivists, were not even experienced hospitalists, but they were all trained doctors and had some knowledge. So we did 2 things. One is we provided training and resources so that every doctor who came in had access to a primer on, for example, how to be an intensivist if you're not an intensivist, or how a ventilator works. And in addition, we created a tiered staffing model adapting the Society for Critical Care Medicine's tiered structure that really was very effective for us. So we could have one intensivist, in essence, managing up to 90 patients using a tiered approach where there were other physicians who were not board certified intensivists necessarily, but they would report up. And we had, that allowed us to scale appropriately and deliver the kind of care that was appropriate for the patients who were in our hospital system. Same time, we never had a shortage or came close to a shortage of PPE. And at the same time, no doctor practiced any medicine in our health system until they had the adequate PPE, until they were trained in the proper use of PPE. Those were essential and have been essential to our workforce. But I'll also say, even with that, about 10 to 15% of our workforce has developed COVID. whether it was in the healthcare setting or in the community setting is never, ever clear. But we did take a very stringent measures to ensure that our staff were and are protected and trained properly in how to use the equipment. So we peaked on April 11th. Due to the impact of social distancing, the peak really got to 2,000 inpatients and 500 in the ICU. And the model actually worked pretty well as it took into account social distancing. You can see the blue dots and the black dots tell us where we are in terms of what the model would project. So that was the peak, and then every day now, the number of new patients has been decreasing. So that gets us to about here, where we had over 1,500 patients on April 4th, to here on the 14th after the peak, where we're able now to discharge a lot more patients. And as of that date, we discharged about 2,400 patients from the health system. And then, of course, we've created new structures to manage the patients who are not going to survive COVID, including a new palliative care unit just for COVID. Okay, so now I finished the piece about the preparations. I finished the piece about matching supply and demand. And I want to talk a little bit, if I could, about our experience with the disease itself. Because all along, while part of what I do, at least, is focusing on the infrastructure and the institution, I'm also seeing our patients, and when I'm rounding on the wards and talking with our doctors, and this is science and medicine on the fly, because we're starting with a disease that we don't know much about, and we are learning something new every day. And I think lesson number one we learned is that this is not ARDS, run-of-the-mill ARDS. Not at all, because in run-of-the-mill ARDS, patients have stiff lungs, they're not compliant, they require very high plateau pressures to get adequate tidal volumes, and that's not the case here. The lungs are pretty compliant in patients, at least early on, until things go terribly. But early on, this is not ARDS. This is something different, and that means that the pathophysiology of this process is not the run-of-the-mill ARDS, where you have viral injury to the lung epithelium, it sets off a cascade, and then the lung injury set off by the viral illness then manifests itself as hyaline membrane disease that's diffusely applied and homogeneous as one would see in ARDS, mostly dependent. It's not what we see here. It's something different. But what we saw was that the mortality was high, as we would expect. And if I were to ballpark our numbers now, and the numbers aren't firm, when we focus on patients who are critically ill, about 25% die, 25% survive, and 50% are left with chronic respiratory failure. That's kind of where we are right now. The data are maturing every day, but that's kind of where we sit right now. The mortality that was reported from the critical care units from other sites was higher, but that's what ours is right now. And certainly it's subject to change as we get more experience with it. The treatment approach, even though it may not be RDS, is similar. The best thing we can do for ARDS is not to cause any more damage, right? So it's protective lung strategy. And we did that, and we monitor that. We had a dashboard that told us the tidal volume for every patient, the ideal body weight for every patient, the mLs per kg delivered to every patient, what their plateaus were, what the P to F ratio was, and we used that information to make rounds in the ICUs and make changes to the ventilators, and also to know who we should prone, targeting a P to F of 150 for critically ill patients as who to prone. I'll go into a little bit more detail as to the therapeutic strategies that we employ at Mount Sinai, so I won't spend a lot of time on that. But I also want to emphasize that this is much more than numbers. This is much more than disease pathophysiologies. These are people. And one of the things that we did in the MICU is we converted the MICU from a non-positive pressure unit. We used to have two negative pressure rooms in the MICU. And so the MICU underwent a over the weekend construction whereby every room was made negative pressure. And to do that, we put windows up and closed off every unit bed. And then we then used the windows as our whiteboard. And we started recording data on the whiteboard. And you can see on the middle photo, there's a patient there on a ventilator, and the right-hand side is taped up some vital sign information. We also now directly write on the vent settings and the last blood gas. But also for every patient for which we had information, there was a about me section. And so then that allowed the team to know a little bit more about the patient than they would otherwise know. And I thought, and we all thought that was important to try and bring back and bring to front center where it belongs, the humanity of what we're dealing with as in the ICUs. So this patient here, about me, I have 3 grown daughters, and my daughter Moet is my contact, and then another patient names the love of his life, which is his granddaughter. So these are the really important pieces that go into caring for patients who are afflicted by a pandemic such as COVID. And the impact is really quite significant on all the different caregivers. I've never seen caregivers look so drained and so worn down and beaten up as I've seen those who are caring for patients in this COVID pandemic. The institution has appropriately responded and responded really well by providing on-site resources. There's a liaison from mental health services for every single unit with 24/7 access to every provider and multiple different initiatives to make sure our providers get sufficient rest and resources to help cope right now with the pandemic. And we understand that there's going to be a PTSD type of syndrome that will affect many of us who have been exposed to this. So this is Dr. Rich's slide, and it kind of outlines with more precision the approach to treatment for patients with COVID. We separate out the potential treatment algorithms based upon whether somebody has moderate, severe, critically ill disease severity or multi-system organ dysfunction. From the get-go, for hospitalized patients, we've been regularly using hydroxychloroquine. We acknowledge the evidence base for using it is relatively weak. There were some anecdotal evidence that we and others had experienced that demonstrated it might have a benefit in some individuals. We screened everybody before they received the drug with the EKG and didn't use it in anybody who had an abnormal EKG. And so that's been part of our regimen, plus minus azithromycin. None of us think it's been particularly impactful. But we've used quite a bit of now tocilizumab and other IL-6 blockers, and we have multiple clinical trials going on at the same time. We have a very robust clinical trials oversight committee that vets every single proposed drug or technology that is put forth as a potential agent for study in COVID. We have an independent review by experts of each of these proposed modalities, and those that pass muster then are approved by the oversight committee and then put into trial. So we have trials for antivirals such as remdesivir. We have trials for convalescent plasma therapy, which Sinai has done in about 60 patients thus far, with appears to be a good response. We have trials for mesenchymal stem cells. These are allogeneic, and that's been used in about 15 patients thus far. We just started a GM-CSF trial, and we're about to start a trial for eculizumab, which is a complement inhibitor. And so pretty much any therapeutic that we want to introduce, we do so in the context of consent, off-label use, or more commonly in the setting of a clinical trial, phase 2 or phase 3, depending upon the trial design. One of the early observations we made that has been made by others was that the pathophysiology of this illness seems to involve significant involvement by the coagulation cascade. The observations ran all the way from having difficulty in doing dialysis because the catheters kept clotting, to patients having PEs, to more subtle abnormalities, such as seeing that there was exorbitant VQ mismatch in patients with shock that seemed to imply that there may be intravascular or endothelial thromboses that were contributing to the pathophysiology of this disease. And it was about a week ago Saturday that when one of our faculty, who Corey knows well, Human Poor, came to me and said, I got another one. And what he meant was there was another patient he had with the same exact physiology. These are patients, they were critically ill, they were getting worse, the pressure requirements were increasing, they had high minute ventilations and yet had a PCO2 that was quite high and a PO2 that was quite low, and looking a lot like, almost like a PE without a documented PE. A lot of them had opacities on their x-rays that could have been ARDS or pneumonia or infarct for that matter. And so what was done in the setting of progressive shock with a possible submassive or possible massive PE, the patients were given thrombolytics, TPA. And the physiological response was dramatic. The blood gases changed right away. The dead space, in essence, went away. The PCO2 is normalized. The pressure requirements also decreased in those two. And that same weekend, there were another 4 patients who had similar physiological improvement. One patient did die right away. And right before death, that patient had an echocardiogram that showed a huge RV thrombus that was totally occluding vascular and cardiovascular output. So but what this did was it kind of established, for at least for some patients, a pathophysiological mechanism of disease progression that involved endothelial injury, endothelial thrombosis, and vasodilatation, almost like a thrombosis combined with hepatopulmonary syndrome all together as a result of endothelial dysfunction, perhaps mediated by complement or some other inflammatory cascade upstream that is still being characterized at this time. So Human got some press out of this, and for those of you who don't know him, that's him over here. And then there's a case series that's been submitted for publication, and this is just an example of what is seen here. Here's a patient looking at the PO2 over here. The PaCO2 really is inversely related to the PO2. Patient gets TPA bolus followed by continuous TPA and heparin, and the PO2 goes up and the pressure requirements go down. And this is representative of the pathophysiological changes that we saw in the other patients. The principle really was that thrombolytic alone was not sufficient because this process repeated itself after the initial thrombosis. And by process, I mean that dead space and the shock. And the patients typically would require another dose of TPA. So then it was decided to add heparin on to maintain patency if possible, or prevent reocclusion if possible. And that seemed to be effective. And then subsequently now, we're moving towards changing the thrombolytic agent, and we have a new protocol, off-label use, administered only with consent, using tenecteplase instead of TPA, with concomitant antiplatelet therapy to try and evaluate that under a study protocol to determine the pathophysiological and clinical outcomes that may be associated with that. So this is really science on the fly that not everybody is comfortable with. Some people are much more comfortable with the usual pace of science. We don't have the ability to wait for that. So we have to move quickly to establish robust peer-reviewed protocols and obtain consent for these potential life-saving therapies in the appropriate clinical arena. This is some details about our convalescent plasma program, which has been increasing all the time. People who recover from COVID then come in, have antibodies tested. If their titer is greater than 1 to 320, they are invited to participate and donate plasma, and we administer that plasma early on in the course of illness for hospitalized patients. And then I'm sure you all read this paper. This is the uncontrolled study of remdesivir that looks pretty darn good. We all have problems because it is an uncontrolled study, and we all rightfully maintain a level of skepticism for this uncontrolled study. But when you compare this uncontrolled data to some of the clinical experiences that we and others have, there does seem to be a potentially significant clinical benefit from this drug for patients with its antiviral properties. And we'll know more about this for sure very soon. There are very large randomized trials that are in progress and accruing. So there'll be much more data at a higher quality as we go forward. Okay, so now going forward, I told you up front that in the future, we're not going to go back to normal. It's going to be a new normal, and that new normal will persist until we have a vaccine or until we develop herd immunity. There are multiple different projections about what that timeline is going to be, and there are multiple different projections about what kind of testing is going to be required in order to move to a containment phase from the mitigation phase we're in now. You can't move to the containment phase until the disease prevalence is way down. In fact, in China, the mitigation steps were not released until there were no new cases for 2 weeks. The United States is not going to have an appetite for that. So there's going to be reopening, and the only way that it can avoid significant second waves is if the reopenings are accompanied by significant testing, so we can have a really robust containment strategy. And so then you can try and look into the future what that's going to mean. It's going to mean that we're going to need widespread testing, and some estimates that have been put forth by economists such as Bill Romer at NYU, Nobel Prize laureate, suggest that the type of testing the United States will need would involve 20 to 30 million tests per day in the US in order to have a adequate containment strategy. And then you have to look and see what kind of testing we're talking about. He's talking about testing for the virus. There's also testing that can be done to determine who's immune to the virus. And both pieces of information are important. And so we can think about what the implications of these tests will be. So somebody who has an antibody titer is then likely to be immune and less likely to develop a new infection. It doesn't mean they can't carry an infection that they acquired from somebody else into the workplace or into a sports arena, but certainly they're less likely to have a new infection. And then, of course, there are people who will test positive for COVID, and they should be best treated by being isolated, and their contacts should be traced in a containment strategy. And then there are those who test negative for COVID recently. And recently is really a matter for discussion, whether it's 24 or 48 hours and what's most relevant. And they would also be of low probability of shedding virus at that particular time. And so that information can be useful and helpful. And then you have those who just haven't been tested, either recently or at all. And then we have no idea. We have no idea because we know that there's a large number of asymptomatic carriers of this virus. So relying upon a history of symptoms or a fever may not be adequate to know who is shedding the virus and who is not. So these are the types of testing that will need to be incorporated, the types of results that will be generated. And you can just imagine that these results will be used to guide access to consumers and to staff and employees and employers based upon the results of these tests at healthcare venues, at gathering venues, at supermarkets, etc. We followed China in terms of the disease course that we've seen here. It is certain that we're not going to follow China in terms of how the follow-up is being done there compared to here. In China, everybody now walks around with a QR code on their phone, and this has been put forward by Alibaba, and people have either a green code, a yellow code, or a red code, and that's based upon travel history and symptoms, which may be which may be acceptable in China because, as I mentioned before, there were no new cases for 2 weeks, and the prevalence of the disease was very low before they went to a strategy of containment. And so these QR codes are necessary to gain access to places like Shanghai Disneyland, which is what you see below, where the QR code gets flashed, and even if it's green, the temperature gets checked at the door, and then one can gain entrance in a socially distant fashion. So you can just imagine that there'll be modifications on how we used to interact with each other before that will be introduced into the way we're going to interact with each other in the future. And of course, the goal is to prevent a second wave or a new wave, because we've all seen the human tragedy that's ensued as a result of us experiencing this first wave. So thanks for the opportunity to share with you this journey and what we've learned. And now I'm going to turn my attention to the chat if we have time. And Sharon, you just tell me when
Go ahead.
we should stop. Okay. Looking for the chat box. I got it. Okay. All right. First question came from David. I answered your question. Anthony says, can't see the bottom of the slides. Whoops, sorry. Phyllis said, well, what are the statistics around race and ethnicity? I don't have the data on that, but that's really interesting. It's not, so there are definitely disparities with regards to the racial, ethnic distribution of patients who have this disease, whether it's genetic or whether it has to do with the environment that individuals lived in, and the ability to be able to be distant or not is not clear, and we'll learn about that. I don't have enough information to answer that beyond what I just said. That's a really important question, and one that everybody is struggling with, especially in New York right now. Can you speak as to whether you found ARB or ACE independently related to severity? We have not seen that. There's a lot of interest in ACE in particular, since that is a receptor for the virus and it's in the respiratory epithelium. And one of the initial responses that we heard was, well, the ACE is the receptor, so we should take patients off any medications that may have an impact on that. And then the AHA and other organizations said, don't rush into that, because it's not clear whether ACE function is important for harm or important for response to the virus. And so don't have information on the correlation with severity, and we don't have information as to whether the medications have any impact on that either. On the second question about race and ethnicity, and unfortunately I don't have good data today. It's being looked at. I mentioned that we have a large clinical trials infrastructure. We have an even larger data sciences infrastructure, where every single patient is being entered into both a data registry and a biological registry, where we've been able to collect biospecimens for processing by our immune monitoring core, and for lung-specific assays and immune-specific assays. So there's going to be a lot we're going to learn from this, both in terms of answering the questions that you have about race and ethnicity, and also about the biology and the immune response. Do our trials undergo typical IRB review? Yes, but the typical rules of engagement have been suspended for almost everything that we do. So you know, it used to be when you had an IRB protocol, you could have a fellow spend their entire research career thinking about an IRB protocol, writing it, sending it, submitting it, and getting it back and forth 12 times. Now it's in a week that from soup to nuts, IRB gets submitted, reviewed, approved. And that's a long one. And same things apply to onboarding a staff. It used to be when we would hire new faculty, we would give them a start date for 4 months after they signed on the dotted line, because that was how long it took to get them credentialed. Now, we hire somebody on Friday and they work on Sunday. So those are just a couple of examples of how the rules of engagement have been changed. We could do telehealth now and get paid for it. So in response to the crisis, I think we've been able to demonstrate that we can do things a lot faster than we would before and still be really careful and meticulous about how it's done. And so, yeah, it's still a stringent IRB approval, but under the pressure of time, it's being done much faster and as well. Have there been problems with accrual? No. Oh my. The accrual for these trials is really very fast, and these trials fill up quite quickly. And I think part of it is that physicians as well as patients understand that for those who have severe illness, the outcomes are quite poor, and that the patients are really quite open to investigational approaches. And so accrual's been very fast for these trials. About testing and return to work or community, from Carlene. If one is tested and negative, is that it's reassurance at that moment? However, couldn't they be infected hours later and then be asymptomatic? Yes, right. So there are no absolutes in terms of the implications of the testing. We know even up front, the sensitivity of testing is maybe 80 to 90%. So we have that limitation. And yeah, you're right that somebody could be exposed right away and then come down with the infection. I think the testing changes the probability of somebody being actively infected or not actively infected. It doesn't make it zero. It doesn't by any stretch of the imagination. So the information has to be used appropriately and properly. And that's a challenge. Thank you from Nick. You're welcome. Are the lectures going to be available online? Yes. From David, has it been determined if increased exposure? We did that one. You really want that answer? I don't have that answer. Whether increased exposure to the virus is linked to more severe symptoms. Okay, I'm one of the fellows seeing a lot of Hispanic population in the COVID MICU. Yeah, and I think it'd be really important to understand what are the variants associated with different races and ethnicity that make individuals either more likely to become infected, and are there similar factors that make those infected more or less likely to have a severe versus a benign outcome? I mean, you've all been exposed to people who've had the virus. Some just have a bad cold. Some get really, really sick. And that is really one of the major questions of what determines that heterogeneity in terms of the severity of illness. We heard so much about the ventilator shortage in New York City. Were you able to share your BiPAP? Yeah. Were you able to share your BiPAP to vent conversion for the hardest hit hospitals, at least according to the lay media? Yeah, so one of the hardest hit hospitals is Elmhurst Hospital, which is a Health and Hospitals Corporation hospital, which we have an academic but not a clinical affiliation. And we've made our protocols and are shipping over our BiPAP devices and sending over our personnel to help train them as an initial site to use this technology. And we also are sending several hundred devices that we have in our warehouse. We received a total of 2,000 devices donated for these purposes. And we're sending several hundred to the state of New York for redistribution. We've received inquiries from New Mexico, the government there, as they're preparing for their surge, and also from South Africa. Oh, why do you think children are not being affected? Yeah, I don't have the answer to that. I'll tell you though, we do have some kids in our ICUs who are sick, very sick from this, but the prevalence is much lower in hospitalized children. But you know, I'm sure we're all very thankful about that children are less severely affected by this. Can you comment how many patients intubated make it to extubation beyond about 25% make it to extubation, and that leaves 50% who don't. And that's our chronic ventilator population. And you can imagine that is a bottleneck, if you will, in terms of the supply of critical care beds for those who continue to come in. And so we're creating new resources, new hospital beds at hospitals that have capacity to take care of chronically critically ill, LTACs, if you will. So we're doing that this week. You reported that a large percentage of recovered patients will have chronic pulmonary, oh yeah. Well, so we will have a post-COVID monitoring entity as part of the Respiratory Institute for both clinical and research purposes. It'll be analogous to what was done in New York for the World Trade Center. So we will do physiological testing, exercise testing, imaging to characterize the long-term sequelae, and we anticipate and expect that it's going to be significant. And we will join with others in a collaborative effort to characterize that.
Hey, Cap,
Yeah.
this is Sharon. Actually, I've gotten the suggestion that you stop sharing your slides and we see you.
Oh, you sure? All right.
Yeah.
All right, fine.
There you go.
All right. Okay, yeah. Okay, so we're making headway here. Oh, thank you, Anthony. Oh boy, I lost my place. Ventilator. Oh, what children reported a large. Okay, yeah. Can you perceivably see how on earth Sweden has opted to not require any major mitigation strategy? I don't know. I don't know. I worry a little bit about Sweden. I worry a lot more about Texas and Florida, where they don't think that they need to mitigate. And the reason I worry is because we know the virus jumped from Wuhan to the state of Washington, and it jumped from France across the Atlantic to New York. So if it can cross those huge bodies of water in 10,000 miles, it can cross a border much easily. And so I think, unfortunately, it will be just a matter of time before there's significant ways that these states that don't believe or don't want to do social distancing. So I don't know about Sweden. I'm much more worried about some of our other states. Any response, any information on response to hydroxychloroquine and genetic makeup? No, but we'll learn that. We're doing genotyping on everybody, and we know who got hydroxychloroquine and who didn't for patients who have enrolled in our registry. Oh, any major bleeding complications with TPA, like ICH? Yes, we've had bleeding complications. So we introduced a widespread anticoagulation protocol where patients who are thought to be at high risk for deterioration as dictated by high CRP or elevated D-dimer, 2.5 is our cutoff. I don't know what assay you use, but for us, that's our assay. They were started on systemic anticoagulation. We didn't have bleeding or ICH on TPA, but we did on heparin. One was traumatic, one not traumatic, and there have been other ones. So we're looking at our policy and trying to see if we can peel back a little bit to eliminate those who may be identified for higher risk of bleeding. But clots are really common. We have multiple patients who leave the hospital and then they come back 3 days later with a huge PE, an infarct. Whereas beforehand, we didn't even have a clue that that was going to happen. The D-dimers were normal before discharge. So this clotting is an important manifestation for those who have severe disease. And we don't know enough to identify who's at high risk for clotting and who's going to happen. But we do think that there is a benefit from anticoagulation as it's being applied. And we're studying that. We'll learn about that. We have had patients with HIV and COVID-19. And some of them have done well and some of them have not. We don't have enough information to say whether the outcomes are different. Is there a trend on disease progression in terms of time? 8 to 12 days is the key window in our experience. That's the window when people either are going to get better or they're going to get worse. And so if somebody's still sick during that 8 to 12 window, then those are the patients we're more aggressive about making sure that we're considering anticoagulation, IL-6 treatments, and steroids, if appropriate. the question about mutating of the virus. So yeah, there are several subtypes available, and right now the most important information we get from the subtypes is knowing the epidemiological origin, and that's why those really nice papers from Yale and Sinai and NYU gave some information as to the origin of the New York virus coming from Europe and the Washington virus coming from China. And then the related question is whether those differences in sequence have are associated with any differences in the course of disease. And we don't know. Not like me, but even those who wrote those papers don't know what the functional implications are of those sequence alterations. But it does seem that it mutates or changes slowly, which is good, makes a vaccine potentially more feasible. Observation about GI symptoms. So most patients present with respiratory tract symptoms, some with GI symptoms. It's less common, but anecdotally and maybe accumulatively, the course is worse in those who present with GI as opposed to respiratory symptoms. Don't know why. Should we anticoagulate all COVID patients despite severity? No. The objective is to anticoagulate those who are at the highest risk for clotting, and not to sound facetious, that's really the goal. The challenge is to know who's at high risk. And typically we focus on those who are around day 8 to 12, who aren't getting better, who have an elevated CRP, elevated D-dimer, with the absence of contraindications, anticoagulation. That's who we focus our attention to. What about the use of CPAP in the hospital or at home? I've changed my thinking a little bit about CPAP in the hospital via mask interface. So the reason I've done that is because now we can take a mask and it has an expiratory valve, and we can attach a HEPA filter to that expiratory valve, and we can then mitigate against the release of virus, at least through the expiratory port of the mask. And so we have 10 or 15 patients being ventilated through a mask with either BiPAP or CPAP. The home question is really interesting. And anecdotally, and I think it'll be written up, and in fact, there's a clinical trial that Naomi Shah here is launching to examine the hypothesis that use of CPAP in patients at home may reduce hospitalizations for those who have COVID in the ambulatory setting. And the anecdotes come from patients who have sleep apnea, who have a CPAP device and have COVID and are able to avoid coming to the hospital. And I think that in terms of exposure, the issue is different because everybody in that home has already been exposed to virus. And so using a CPAP machine won't likely change the number of people who will be exposed to virus at home. Okay, so question, Mount Sinai Health System seems much better prepared and responded earlier than other hospitals in New York. Can you please compare? I can just talk from our standpoint that, and I take zero credit for this because the strategic command here at our hospital system did a superb job and pulled all the strings and all the levers as well as I think anybody could in a health system. And so that's why I think it seems appropriately that the Mount Sinai Health System was well prepared for this. With the caveat that even though we were well prepared, we were still caught short, particularly in terms of staffing at our community hospitals. The other large hospitals in New York, I think also were well prepared, but some of the hospitals that are less well resourced at baseline were unable to make the kind of expenditures that our systems made to be prepared. So I told you about all the things that we did and how fast we did them. And I never saw a purchase order go from request to being fulfilled so fast. 30 minutes, whether it was a $35,000 piece of equipment times 50, or whether it was something like a construction initiative. We spent and spent and spent and spent hundreds of millions of dollars. And that allowed us to be able to be prepared, but certainly not every hospital was able to do that. So it was strategy and resources. Question about BCG vaccination. I don't have any information on that. I'm sorry. I have to whiff on that one. Oh, have you seen any incidents of reinfection in people? No, we haven't seen any clinical evidence of reinfection. But I'm sure you've all seen reports that there have been individuals who've tested negative and then tested positive. Whether that has to do with the sensitivity of the assay or something else is not clear, but we don't have any evidence of clinical reinfection that we've observed thus far. And I think we all hope that that doesn't happen. Clotting during central line, yeah, we see that. It's a problem. Neurological, yes, a lot of patients have neurological symptoms. Sometimes this behaves almost like a TTP, where there's renal failure, which is really common. Anywhere between 30 and 50% of our critically ill patients require some form of renal replacement therapy. So there's a syndrome of clot, of renal failure, of neurological dysfunction. What's missing is thrombocytopenia and hemolysis, but some of the pathophysiological mechanisms that are important for conditions like TTP seem to manifest also for those who have severe COVID. And the bottleneck, yeah, so that's the last question is, there are a lot of bottlenecks in terms of dialysis, both in terms of machines and dialysis nurses and dialysate. Sinai was very well prepared. We have enough dialysate. We're able to have enough machines. We're short on nurses, so we're really working to increase the supply of nurses. Other hospitals around the city are not able to provide all the dialysis that they would like to provide. We're looking for help from the federal government, and many of us are in contact to try and get those resources available. Steroids in some patients. We use steroids with anecdotal evidence of response. We don't co-administer steroids with tocilizumab because there were multiple reports from clinical trials of an increased incidence of gastric perforation in patients who were treated with concomitant tocilizumab and steroids. So we don't do that. Yeah, the question is, what's the mechanism of the neurological dysfunction? I don't know. It's an important question. I don't know. And I think that's it.
Can I ask you a question? This is Jack.
Of course, Jack.
Have you done significant numbers of autopsies on the people that passed away? And are there lessons on the autopsies that potentially were not evident before the patient was autopsied?
Yes. We've done at least half a dozen autopsies, and there are more that are coming. And we don't take that lightly because it's infectious, and the pathologists who do the autopsy are really subjecting themselves to significant risk. So, when I have my conversations with our lung pathologists, and we've been spending a lot of time together, we appreciate what they're doing very, very much. And so we've been very interested in this thrombosis pathway. And so last week I'm up there with our pathologist, and we're looking at a series of 4 autopsies that were done, and we're not seeing any clot. Some of the patients had the physiological derangements that I mentioned to you before in the series from Wuhan. One in particular did, but we didn't see clot. But what we did see was inflammation in the endothelium that really stood out, that was surprising to us. It's not ARDS-like picture.
Is it a vasculitis?
Like a endothelitis, yeah.
Endothelitis.
Yeah. And when we saw those patients that hyaline membrane disease, they did have hyaline membranes and they were diffuse, but it's quite heterogeneous, which I think explains the compliance. But we said we said it would be really important for us to have additional autopsies. And so additional ones have been done. And we're starting, I think, to see a little bit of evidence of some small vessel thromboses. And that's on the background of there being some earlier autopsies done before the series of 5 or 6 I just told you about that did show gross clot, we've had a bunch of autopsies showing PE, but the process we're talking about is not a straightforward DVT PE. We see that. The patients have that, but I think what we're also seeing is something more complex than that. It involves a primary endothelial in situ thrombosis and endothelial dysfunction that we're trying to get our handle on.
Wow. Well, this has really been extraordinary. Thank you so much for helping us learn more.
Oh, sure. Thanks for listening.
It's been great. And thank you also for your service. It's we say that in the VA all the time, but it has meaning in all settings. And good luck, and we hope that this situation does not recur very soon in New York.
Yeah.
Thank you very much, Cap.
Pleasure, Jack. Pleasure, Sharon. Thank you.
Stay well, my friend.
You too. Thank you, everybody. Have a good day. Bye-bye.